All right. Hello, everyone. Welcome. Just going to give it another few more seconds. The chat is open. Welcome. All right. Okay. So, hello, everyone. Welcome to the webinar of Why Are Breast Cancers More Aggressive in Black Women? I am Megan Claire Chase, the Breast Cancer Program Director here at SHARE, and I'm also a breast cancer survivor. Now, before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, our podcast, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during this presentation, but the chat is enabled. So please feel free to engage in the chat and make sure to select everyone when commenting in the chat. Once our fabulous speakers finish presenting, we will begin the Q&A portion. Please submit any questions through the Q&A section at the bottom of your screen. And remember that our speakers are unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. This webinar is being recorded, and we'll share this recording in a few weeks with all of the registrants, and it'll be added to our website. Now, I would like to hand it over to our amazing speakers, Dr. Ambrosone and Dr. Yao, to introduce themselves. So the screen is yours.
Hi, my name is Christine Ambrosone. I'm a professor of oncology at Roswell Park Comprehensive Cancer Center. I have been doing research for almost 25 years, and all of it has been around breast cancer. And my first job was in Arkansas, and I became very aware of the toll breast cancer took on African-American women. And because of that, my research is focused on that topic ever since then. Are you hearing me?
You're on mute. There you go.
All right. Hi. My name is Song Yao. I'm a professor of oncology, also at Roswell Park Comprehensive Cancer Center. I am a molecular cancer epidemiologist by training, and I've been working in this field for about 20 years. And Christine, Dr. Ambrosone is my mentor, and we have been working together on our research have been on to understand the molecular and biological underpinnings of breast cancer in a diverse population. Very happy to be here.
So should I?
Christine, can you share your screen?
Yeah. Okay. Are we there?
Can you switch the display?
I knew this was going to happen. I'm sorry, everybody. Okay. Are we good now?
Yep.
Perfect.
All right. So again, I'm very happy to be here and to talk with y'all. And if there are comments, Megan Claire, feel free to interrupt me if there's questions, things that aren't clear that I can clarify, because we get used to talking to people who do a lot of the same stuff that we do, and sometimes forget if you're not coming from the same background when it comes to research. So through time, breast cancer rates in the US were the highest in white women and quite a bit lower in African American or Black women. But through time, rates in Black women have been going up and rates in white women have been coming down, and they're just about the same now. But the big difference is that more Black women die from breast cancer than other groups in the US, and the death rates are about 40% higher than white women. So here's a graph. If you look along the bottom, it's showing years from 1975 to 2020. These are rates. And on the other y-axis is the rate per 100,000. And the gray line is for white women. These are death rates. And the hot pink is for Black women. And you can see that they were kind of the same around 1975, 1980. And then they started getting much lower for white women and higher for Black women. And part of this is because white women are more likely to be diagnosed with estrogen receptor positive tumors that can be treated with tamoxifen or anti-estrogen. So I think that was part of the reason that the rates started going down for white women, but stayed higher for Black women. And here's other types of graphs where we can look at incidence. So this is the number of cases diagnosed and mortality. So the pink bar is the incidence and the hot pink or the red is mortality. And so you can see in this figure on the left side, incidence for white women, 133.7 per 100,000, and for Black women, 127.8. So there's a kind of similar, but you look at the death rates, 19.7 for white, 27.6 for Black women. So we've got higher mortality. And here's another kind of graph. I'm not going to keep torturing you with these to get your heads into, but this is the ratio of Black to white rates. And this is incidence. So Black women are 0.34, 34% more likely to be diagnosed with breast cancer when they're young. So this is up to age 30, 13% up to age 40, and then the rates are pretty similar. But the red ones are for mortality, and you can see for younger women before age 30, Black women are 2.4 times more likely to die from breast cancer, and 30 to 39-year-olds 1.86, and same thing. So you see these much higher mortality rates for Black women. They come down pretty much as women get older, but still see this disparity. So Black women are more likely than white women to be diagnosed before age 40. And there's a lot of research going on now to try to understand why this is the case. But within all age groups, Black women are more likely to die of breast cancer than white women. More than twice as likely to die of their breast cancer if they're diagnosed before they're 40 years old. Now, as we try to figure out why this is, I think some of the higher mortality may be due to less access to screening. Right before the talk, we were talking about women who live in rural areas. When I was in Arkansas, there were women who lived so far from places to get screened, no public transportation. So that between that and a lot of other social and cultural reasons, there may be diagnosis at later stage, which is less hard, less easy to treat. And then also perhaps less access to best possible treatments. If you get a lumpectomy, you need to have radiation therapy every day. Now, if you live somewhere where there's no good transportation, how are you going to get to the center to get that treatment? So this again can play into poor survival rates. But then we're learning more and more about other social and structural drivers of health. Lack of private insurance, maybe getting care, but at facilities that are unaccredited or low resourced, institutional and social contexts, and then neighborhood. Just listen to a talk, and the big take-home message was place matters, neighborhood matters. And this is a schema that Rick Bornecki helped put out in 2008, and it's been adapted now by Scarlett and Gomez to this format. But starting at the top, these social and structural causes of disparities that people are becoming more and more aware of, and trying to figure out what can we do about it. So social conditions, policies, poverty, social class, institutional contexts, healthcare, religion, media, economic and legal systems, and then again, affordability and accessibility of healthcare. And then we look at the social and physical context, and this could be, again, neighborhood, socioeconomic status, income, education, poverty level. People are using this area of deprivation index now to try to hone in on how this may contribute to poor treatment outcomes. And social relationships, or just saw something the other day that people who really participate, who have spirituality, can play a role in better outcomes. And physical context, where you live, again, walkability, parks, exercise is great. Can you really get out and exercise where you live? Healthcare access, again. And then Scarlett has grayed out these individual and demographic and risk factors, because they're much more interested in these factors at the top, the social and structural. But we know that individual demographics plays a role into survival outcomes, age, socioeconomic status, education, race, ethnicity, and then risk behaviors. Tobacco use is associated with poor survival outcomes, the alcohol, diet, and then biologic responses and biologic and genetic pathways. So this is something that's been around, but it's really on the radar now. People are thinking much more seriously about how those boxes on the top can be playing a role in treatment outcomes. But one area of work that we've been involved in for a number of years is really looking at tumor biology, because Black women are more often diagnosed with tumors that are more aggressive and they have worse outcomes. So tumors that are high grade, but also that lack receptors for estrogen, progesterone, and HER2. And these are triple negative breast cancers. And triple negative breast cancers are problems because there are no targeted therapies. If you have a tumor that is estrogen receptor positive, it can be treated with anti-estrogens, aromatase inhibitors, tamoxifen. HER2 can be treated, positive tumors can be treated with Herceptin. But if you don't have those receptors on the tumor, there aren't specific treatments for them, although more and more now are becoming available. But these triple negative breast cancers also have poor outcomes in and of themselves. They appear to be more aggressive in biology. So again, this is looking at breast cancer rates, and this is incidence, and this is from 2000 to 2019. Along the bottom, the top is rate per 100,000. And overall breast cancer rates, as we already talked about, are higher for white women, and then Black women in that hot pink line. And below that are Alaskan Indians, Asian, and Asian Americans and Hispanics. But then if we look by hormone receptor positive, so this is if it's estrogen receptor positive, we see the rates much higher for white women and not so much for the other groups. But hormone receptor negative tumors, the white women are clustered down there with the Asian Pacific Islanders and Hispanics, and Black women have much higher rates of hormone receptor negative tumors. Again, these are the tumors that cannot be treated with anti-estrogens. And this is rates of triple negative breast cancer by group. And on the top here are African Americans, non-Hispanic Black women. The rates quite a bit higher than the other groups down on the bottom. So more estrogen receptor negative tumors, more triple negative tumors, more aggressive tumors, and less responsive to specific treatments. So the question that's been driving me since, I don't know, for 20 years now, are why are these cancers more common in Black women? So let's talk about what we know about breast cancer. What are the risk factors for breast cancer? Because it could be that there are some risk factors that are more prevalent in Black women than in white women. So overall, breast cancer risk is increased with family history, radiation exposure, like when the US bombed Japan. Girls who were about 12 or 13 at the time, they're the ones who develop breast cancer at a later age. Hormone replacement therapy, we know that it causes breast cancer. Alcohol consumption, overweight postmenopausal women, and low physical activity. Other factors reduced risk with later age at menarche, when you have your first period, having children, earlier age at first birth, and earlier age of menopause. So having late age of menarche, early age of menopause, it's kind of shortening that window where you're menstruating, where you're going through those hormonal cycles, and where the breast is exposed to hormones, because it's that exposure of the breast to hormones that really is associated with breast cancer risk. And historically, overall breast cancer, having children, has reduced risk of breast cancer. Now, the majority of studies that those data come from examined overall breast cancer risk, not by estrogen receptor status. And the studies were mostly conducted in populations of older white women. About 90% of older white women are estrogen receptor positive. So these known risk factors apply primarily to ER positive disease. And it was really unknown if risk factors differed by ER status, or if they were differing risk profiles for Black women. So when I was in Arkansas, I started the study of breast cancer in African American women, and moved to Mount Sinai in New York shortly thereafter, and started a study there, the Women's Circle of Health study. And this has been in New Jersey and in New York. And this has been ongoing for a number of years, and we collected a lot of data. But when we started, it's a big procedure to do a study like this. You've got to get grant funding. You have to figure out how to do it. You've got to get approval from your institutional review boards, and you have to start contacting patients. It's really a few years before you've got a study where you actually have patients who are participating. So we were chunking along, interviewing people, getting this study done, and but first, I'm going to teach you a little epidemiology, because I was going to talk to you about odds ratios. So in epidemiology, we use odds ratios or relative risks to give an estimate of the risk associated with a certain exposure. So an odds ratio is the ratio of the risk of disease if you're exposed versus those who are not exposed. So if the ratio is 1, there's nothing, right? It's the same thing. There's no association. And a good example is lung cancer and smoking. Say we've got 100 people with lung cancer, 100 people without, and maybe 90 of those people with lung cancer smoke, maybe 40 of those who don't have cancer smoke, and then non-smokers, maybe 10 with lung cancer, 60 without cancer. So there's this formula that we do, and you come up with an odds ratio, and this would be 13.5. And this means that smokers are 13.5 times more likely to get lung cancer than non-smokers. And this is really our bread and butter. This is what we use to try to identify causes of cancer and the size of the risk associated with it. Now, we really don't want to take something as gospel unless it's statistically significant. And for the most part, people use p-values. We'll set it at p less than 0.05, and this means that if you did the test 100 times, only 5% would it come up wrong. 95% of the time, it would come up showing that same result. So if the p-value is less than 0.05, you say it's significant, but this doesn't really tell you much. So in epidemiology, we like to use confidence intervals. And this is the range in which the true magnitude of the effect lies. So we 95% confidence intervals, the same as p equals 0.05. And we can say with 95% confidence that the true risk lays between this and that. So a good confidence interval, this would be an odds ratio of 1.67. And we could say the true risk lays somewhere between 1.54 and 1.71. So here we're pretty sure that this is what's true, that's about the size of the risk. Whereas you could see the same risk estimate, but if the 95% confidence interval is between 0.65 and 0.89, well, it could be anywhere. So I have very little confidence in that odds ratio. So if the odds ratio equals 1, lays somewhere within that, it's not statistically significant, and we don't have much confidence in it. Okay, now we can talk about data. So we were in the middle of that study, getting people enrolled, and this paper came out that just bowled me over. It was pretty shocking because we always, in the data, we always knew that having children reduced risk of breast cancer. So here in the blue is luminal A, this is ER-positive breast cancer. If we set it no risk, not having children, and this is a reduction in risk for having 1 child, 2 or 3 or more. We see a 30% decrease in risk with having children. It doesn't really matter how many, we see the same thing. And this is like borderline significant, this is significant. But for triple negative breast cancer, we saw very different story, that having children increased risk, 1 child 1.7, 2 children 1.8, 3 plus 1.9. So almost a 2-fold increase in risk with having children. This is counter to everything we've ever known. But that was because we were just looking at overall breast cancer, and we were looking primarily in white women who had ER-positive breast cancer. And what was very exciting about this, though, was that breastfeeding could pretty much take away that risk. So again, luminal A, this is ER-positive breast cancer, not having children, and then those first 2 boxes in the black are not breastfeeding, and then the pink are breastfeeding. For ER-positive breast cancer, same reduction in risk, doesn't matter if you breastfeed or not. But for basal-like breast cancer, we see this 2-fold increase in risk with never breastfeeding, having children and not breastfeeding, but almost no risk at all if a woman breastfed. And this got me so excited because we're talking about this pretty aggressive, fatal type of breast cancer. If we could reduce risk of it through breastfeeding campaigns, that would be phenomenal. So this paper received almost no publicity. I was giving talks out at big meetings. People were not aware of it. And we know that Black women are more likely to have children at a younger age, have more children, and less likely to breastfeed. So it's really important, I believe, for public health for Black women as well as white women to reduce risk of poor prognosis breast cancer through breastfeeding. There were additional studies, including ours, the Women's Circle of Health study, that replicated these findings, but still nobody really had it in their heads that having children increased risk for ER-negative, triple-negative breast cancer, but breastfeeding could take it away. So Bob Milliken, Julie Palmer, and I were at a meeting, and we were out in the hallway, and we were saying, we have really got to do something to get this word out loud and clear, that if you have children, breastfeeding them can reduce risk of an aggressive breast cancer. So we formed this very large study, the Amber Consortium, and we had a number of projects within it. And the first thing we wanted to do was nail that finding of breastfeeding reducing risk of breast cancer. So these, the lines on the bottom, the purple and the green, this is ER positive breast cancer. You see reduction in risk with having children. Number of births is along the bottom, 1, 2, 3, and 4. But the blue and the red are ER negative breast cancer, and having children increases risk of breast cancer. And it's highest for women who never breastfed in that blue line. So as in the Millikan study, we saw reduced risk of ER positive regardless of breastfeeding, but highest risk for ER negative with women who never breastfed. So one other project that we had in this consortium was to look at whether or not immune response could have an impact on more aggressive cancers. And I was an anthropology major as an undergraduate and thought a lot about different populations around the world. And evolution over millennia, we observed numerous differences between populations from different continents of origin. So mankind evolved in sub-Saharan Africa, and it's believed that they had more robust immune responses to adapt to endemic infectious disease, and therefore robust immune inflammatory responses. With migration through Europe and over into Asia, this became less essential, but in sub-Saharan Africa, very important. So it could increase the likelihood of surviving reproductive years, but may be maladaptive in Western modern society. So this was a project that we looked at in the Amber Consortium. And at this point, I'm going to turn it over to Song Yao. I'm going to stop sharing my screen and let him take over.
Yeah, thank you very much, Christine. I'm going to share my screen real quick here. Okay. I hope you can see my screen. All right. So I start from here. Can you see my slide? Okay.
Perfect.
Okay, great. So yeah, thanks very much, Christine, for setting up the stage so beautifully. So I'm going to talk a little bit more about our project to investigate whether our host immunity actually plays a role to lead to the more aggressive breast cancer in Black women. So there have been multiple studies in the literature in recent years that shows there are differences in our immune response to that, and we can see that in modern populations classified, grouped by ancestral background. And those studies make sense because think about that, those results consistently show that a large degree of the population differences in our immune response are actually under genetic control. And how we got those genetic variants, I think one way is through long-time adaptation to our local environment thousands and thousands of years ago when our early human ancestors living in separate continents, and those continents have very different environment. So in order to survive in those environments and survive and thrive in those environments, there are different genetic variants got selected that make our survivors in this situation. So for a lot of reasons, the early human populations and in the genetic background, the more robust immune response have been selected to fight off all kinds of infections of pathogens. So now, when we look at the studies in modern population, and when we collected the cells from donors from different ancestral background, when we compare those, we can still see clearly there are differences. And as Dr. Ambrosone mentioned earlier, that for populations with the genetic background from African origin, they tend to have more pro-inflammatory immune response. And that's just in the systematic, in the immunity. So that means like the immune cells you found in circulation blood. We now know that when tumor occurs, for example, for breast tumor, the immune cells can also be enlisted and become active. And then they have the purpose is for the immune cells to recognize the tumor cells and then to kill the tumor cells from becoming more developed. But over time, there's also a phenomenon called exhaustion. So that means the immune cells, when they keep fighting the tumor cells and then they become exhausted, then their anti-tumor activities become compromised. So when cells express some molecules, we call those inhibitory receptors. For example, the PD-1, PD-L1, LAG-3, CTLA-4, those are molecule names. And you probably have heard some of those like PD-1, PD-L1, because now there are anti-PD-1, anti-PD-L1 immune checkpoint inhibitors. Those drugs targeting exactly those molecules. So when the tumor cells overexpress those, then the immune cells become exhausted. They don't work anymore against the tumor cells. But then we found that in our studies, when we compare the breast tumors obtained from Black and white women, the tumors from Black women tend to have higher expression of PD-1, LAG-3, CTLA-4, those so-called inhibitory receptors. So that means the immune cells in the tumor microenvironment in Black women tend to be more exhausted, although there are more immune cells in the microenvironment, but then those immune cells tend to be tired out and they don't work anymore. So that's led us to hypothesize that this phenomenon, this T-cell exhaustion phenomenon, may explain why Black women have more aggressive breast cancer, and then they may be more likely to die from it. So when we look at this in a different way, as you can see here, we looked at this in two different studies. One is in the Women's Circle of Health study that Kristen just talked about, and another in the TCGA, which is the Cancer Genome Atlas, which are public available data sets. And when you compare Black and white women, and we classify the tumor into 4 different subtypes. So the dark blue color means that the tumors have high expression of good immune cells, but low bad immune cells. While the red color means that the tumors have more bad immune cells, but fewer good immune cells. And consistently, you can see that Black women tend to have more tumor subtypes that have more bad immune cells. So this led us to think this T-cell exhaustion may be one of the reasons that Black women have more aggressive breast cancer. So working together with Dr. Ambrosone and also Dr. Scott Abrams, who is a cancer immunologist at Roswell Park Comprehensive Cancer Center, we together have got a large study funded by the National Cancer Institute to look into the to do more comprehensive analysis of the tumor immune response in Black and white women. And we also launched the New York breast cancer study, which is ongoing study to enroll Black and white women to gather tumor blocks and to get the saliva samples. So we have DNA samples, then we can continue this study, but in a much larger sample size. That will allow us to better understand the tumor immune cells in the microenvironment, in the tumor microenvironment. But also that led us to think whether for the more exhausted immune cells we found in Black women, whether that can lead to different response to immunotherapy. As you know, in the last several years, in the last decade, actually, there have been very exciting development in using cancer immunotherapy against various cancers. So the idea is really to reinvigorate the immune cells, to let them recognize the tumor cells and then become less exhausted, so the immune cells can attack the tumor cells. Then we can have a better chance to cure the cancer. But when we look at the literature on how many Black or other racial ethnic minority groups enrolled in the clinical trials, we don't see many patients there. So we really don't have good data from the published literature to show whether Black women or other groups of women respond differently to immune checkpoint inhibitors or not. For breast cancer, although immune checkpoint inhibitors were first used to treat like cancer, like myeloma, like lung cancer, but for breast cancer specifically, there have been very exciting development in the last few years. So here I show two clinical trials, although both trials targeting the triple negative breast cancer, which we know is more immunogenic. That means women with this type of breast cancer, there are more immune cells in the tumor microenvironment. So that's why a number of clinical trials have tested whether immune checkpoint inhibitors can help to treat triple negative breast cancer, because we know this is a very aggressive type of breast cancer, and women tend to die pretty shortly after diagnosis. So the trial I show on the left is from the Keynote 355. This is for metastatic setting. So that means women diagnosed with a triple negative breast cancer, and the cancer has spread out to outside the breast. And then they gave women with pembrolizumab, which is anti-PD-1 medication, and plus chemotherapy. And then they show that a patient with pembro plus chemotherapy has that's the kind of orange line here. They have a better survival than those with the placebo plus chemotherapy. And this works especially for those who have high expression of PD-L1 in their tumors. And then the trial on the right, that's the Keynote 522 trial. This is a different setting. This is not a metastatic breast cancer, but then this is the early stage triple negative breast cancer. So that means the breast cancer, the cancer cells are still within the breast and they have not spread to the other places in our body. And also they gave pembrolizumab with chemotherapy as a new adjuvant setting. That means that the treatment are given before patient receive surgery, and then they also continue the pembro treatment after the surgery. And as you can see here from the pathological complete response, so that's a way to measure how well the tumor responds to the treatment. The response rate is higher in the patient who receive immunotherapy than those who do not. And when you look at the event-free survival, you can also see a better event-free survival in the patient who receive immunotherapy. So because of these two trials, the FDA now has approved the pembrolizumab for both the metastatic triple negative breast cancer and also for the early stage triple negative breast cancer. So now immunotherapy is an option for triple negative breast cancer, which used to be very hard to treat. So back to our question, because we saw in our study that Black patients tend to have more exhaustion immune cell in their tumor. So we hypothesized whether Black patients actually may respond better to have more benefits from immune checkpoint inhibitors than white women. And there are very few data on this. This is just one recent study from clinical trials, with relatively small number of Black patients. And they actually did show that the Black patients have higher tumor immune lymphocytes than white patients. So that's what we have seen before. But moreover, they show that Black patients have higher pathological complete response rate than the white women, 79% was 53%. So this actually supports our original hypothesis that this might be the truth. But because this study is very small and we don't know whether this is really will hold out when we have larger sample size. So that's why we started a new study we call DIRECT, which stands for disparity in results of immune checkpoint inhibitor treatment. And this study is led by myself and Dr. Charles Kamen at University of Rochester. And The overarching goal of this study is to understand the response to and also toxicities of immune checkpoint inhibitor treatment in Black and white cancer patients. And because the disparity, as Christine mentioned earlier, is a social phenomenon, and there are so many factors that can contribute to such disparities. So we designed this study to be very comprehensive, to cover 5 domains of factors, including individual, behavioral, social, institutional, disease, and treatment factors. So we are investigating all those factors as a potential contributor to differences in patient response and toxicities to the cancer immunotherapy. And we launched the study last year, about February 2022, and now it's about 1.5 years later. We have enrolled over 1,000 patients across the nation, as you can see in the map on the right lower corner, where our patients come from. And we have been very fortunate to have very good response from the patients, and they have been highly enthusiastic to our study. And when looking at our study, because this is not only for breast cancer, but for all types of cancer, we are very happy to see the breast cancer actually is the second most common cancer types in our patient population so far. So we have enrolled almost, we have enrolled more than 150 breast cancer patients, including a third of those from Black patients. So when we reach our recruitment goal for this new study, we will be able to have the necessary numbers and the sample size to understand whether Black patients have better response to immune checkpoint inhibitor treatment or not. So now, in the last couple of minutes, I'm just going to switch gear to talk of something not directly related with breast cancer risk or treatment, but I want to talk about the another very important aspect of the breast cancer survivorship. So that's their cardiovascular health. As we know that after a breast cancer diagnosis and treatment, women are at higher risk of developing cardiometabolic risk factors. So those means like hypertension, diabetes, high cholesterol levels. And this study from, they call it the Pathways Heart Study, Marilyn Kwong and at Kaiser Permanente, Northern California, and Heather Greenlee at Fred Hutch Cancer Center, they show that breast cancer patients after treatment, they are at higher risk of those cardiometabolic risk factors. And they are also at higher risk of cardiovascular events. And they have related such increased risk with certain treatment. Like you may have heard of anthracyclines. So those are a common use type of chemotherapy drugs. And trastuzumab, that's anti-HER2 treatment, radiation therapy, and aromatase inhibitors. So all those can put women undergoing breast cancer treatment at higher risk of cardiovascular events. When we look at this problem by racial ethnic groups, and we can see that even before breast cancer treatment, Black women, which is represented by the yellow bar here, are at higher risk of any cardiometabolic risk factors, or specifically for diabetes, dyslipidemia, so that's high cholesterol levels, and then also diabetes. And also for some of the cardiovascular outcomes, including arrhythmia, heart failure, cardiomyopathy, and ischemic heart disease, and also stroke. So you can see for all those conditions, Black women are at the highest risk of those events, even before breast cancer treatment. So in our data, we also look at what happened after breast cancer treatment. And as you can see here, the yellow line, that's the Black women. And then the blue line, that's the white women. And then the Asian women is the gray line. And then Hispanic women is the red line. So the higher, that means your risk is higher. So we followed up these women, and we found that Black women had the highest risk of all groups to develop any cardiovascular disease after breast cancer treatment, especially for ischemic heart disease and also heart failure or cardiomyopathy. So when we try to understand whether such higher risk is caused by for example, like aging, like different age, different body mass index, or different treatment the patient received. So that's why we use statistical modeling to understand whether after adjusting for all those potential factors, whether we still see that kind of increased risk for this disease in breast cancer, in Black breast cancer women compared to white women. We still see the higher risk. For example, for hypertension, after all the adjustment, Black women are still almost 70% more likely to have hypertension after breast cancer treatment than white women. And when we look at when we did the analysis for cardiovascular disease, so for example, for heart failure and for ischemic heart disease, we try to adjust all the factors we can think of that may put women at higher risk. And we still see after all those factors have been accounted for, Black women still have higher risk of those cardiovascular outcomes. So I think this highlights the importance to look at cardiovascular disease as one important aspect in the survivorship for Black women after breast cancer treatment. So here, just one last, our last slide here, a summary of key takeaways from today's talk. So Black women have more aggressive breast cancer and higher death rate from the disease, and breastfeeding lower the risk of more aggressive breast cancer that can be associated with higher higher number of children births. And then our data have shown that a stronger pro-inflammatory immune response may contribute to the more aggressive breast cancer in Black women. And then this can be targeted by immunotherapy, and we are actively studying that. And also lastly, Black women are at higher risk of cardiovascular disease before breast cancer diagnosis, and then the high risk continues after breast cancer treatment. So that means the cardiovascular health is a very important factor to be considered for women diagnosed with breast cancer. I think that's the end of our talk. Thank you very much for your attention. And I think at this time we can answer the questions you may have.
Wow. So it's so much information, and we in the Black community, we are very aware there are a lot of things that are just so dire. Like, can you give some hope? Because you know, I mean, this was hard to, this is legit research, and to just consistently hear that about our Black community of just this and this, and it's like, yeah, we have higher death rates. Yeah, we have high blood pressure. Oh, yes, we do, because just existing is traumatic. And I just wonder, what is some hope that you can pull out of any of this for our listeners here today?
Sure. Yeah, maybe I can start, and then Christine can chime in later. So yeah, definitely, I fully agree with your impression that when you have been working in the area of cancer disparity for many years, a lot of time you hear that Black patients have poor outcome, higher risk, and then that's certainly not encouraging, and that adds a lot of stress to the population as a whole. But actually, the study we are now doing, we are hoping that if our hypothesis is true, Black women actually may have better chance of benefit from the cancer immunotherapy, because their tumor immune microenvironment is more pro-inflammatory and they have more immune exhaustion. And so the immunotherapy target exactly that mechanism. So if that's true, then we expect Black women may actually have better response to this new treatment. And this study I show here, that's from the another group, they showed exactly that. So when treated with this new immunotherapy, Black women have a better chance of respond to this treatment than white women. So we hope if this is true, then wider use of cancer immunotherapy may help to alleviate the cancer disparities or the higher death rate we have seen in Black women.
If I can comment on that, I think, you know, it's obvious and clear what the whole history of living in the US for Black men and women, and all of the factors that impinge, like right here, and lead to stress. I mean, these are generalizabilities that we're making, but at least now I think people in the scientific community are getting really aware of this now, the structural causes and the social context. And, you know, hopefully this is going to make inroads. We can't change things immediately, but we have to recognize it. And I think the fact that this is really being recognized in the research community and throughout, I think that this word is getting more and more clear to people, you know, that this is something that's being imposed on populations by the whole institutional infrastructure. And we've got to do better. We've got to make it better.
Yeah.
So, oh, go ahead, Dr. Yao.
Oh, you go ahead.
So, you know, what are, you know, because I feel like there is a disconnect between like the research community and then the medical community. Like, I know I haven't heard any of this from my oncologist. How can we, as in the Black community, and even those who are not in the Black community, how do we make sure that this is getting filtered to the medical community, to where our oncologists will believe us?
Yeah,
Yeah.
that's such a hard question, because, you know, there's kind of institutional, academic, but then there's individuals, and what individuals are gonna like take to heart. And we got the medical community, but then we've got the individual doctors, and you know, how do you get the word out? I
Right.
guess we just have to all do our best trying to make that clear.
Yes. So in the chat, this is why it's so important for Black women to participate in research, especially donating tissue and clinical data, so we can learn more specifically for the Black community.
Yeah, exactly. To the point, this is our New York breast cancer study. We are actively enrolling Black breast cancer patients into this study, so we can obtain their agreement to donate their tumor tissues and also their saliva samples and their data and time for us to understand better the breast cancer. Because
and much of this study is focused on stress, you know, in living conditions, and how that may contribute to what's going on with the tumor. We worked with a psychologist in making the questionnaires. And so hopefully we'll really be able to get at how things that impinge upon you in life are going to affect what's going on with the tumors.
yes.
So what are some things that you recommend that we can share within our community about, like, there is research, but just like in the chat, what this fabulous person said, how can we get more of us, to know about, you know, these different trials and research studies that are happening, but also that we feel safe, you know, in giving our information, because that's a huge, you know, issue in the Black community. And I used to be one of them too. I'm like, I'm not giving my information. Are you kidding me? Yeah. How do we know? Like, what do you say to patients like us, so we can make sure that we get this, you know, mentioned in our communities, that there is a need and there want, but we need people.
Right. So the need, clearly, the only way that we're gonna make progress is to be able to do research. And we really need people to agree and participate. But if it's any consolation, that the privacy and the protection of information is so rigorous now. It's really difficult to get a study, and there's all of these checks and balances that we have to go through at our own institution. Every year, your protocol gets reviewed by the institutional review board. And, you know, what are you doing to protect the patients and the patient's information? So it's very difficult to conceive of a breach occurring. I mean, they could occur, but your name is stripped from the data. You're assigned an identification number, and then the link between the name and the data is in a whole separate file. And the data are never analyzed by person. It's always in aggregate. You know, of these, 1,000 women with breast cancer, 50 of them had this characteristic. And so it's never on an individual level. I don't know if that helps. But I hear you. When I first started doing research on this in Arkansas, we sent postcards out to people before we contacted them, saying, what the study was about. And we got one back that said, "Are you people crazy? I'm not going to be a guinea pig." And I think this was 20 years ago. But I think that, there has been a lot of concern about that.
Yeah, I think the medical miscontrust that have been so entrenched in our society, I think that certainly plays a role for patient hesitation to join those studies. If you look at, I think I showed that too, in the clinical trials for the cancer immunotherapy, we really don't have many minority groups there. So we don't know whether patient respond differently or the same to this new treatment. So we certainly need the participation from a diverse patient population to support our study. Like Dr. Ambrosone mentioned that there have been very vigorous processes in our institute and also at the state level, at federal level. We have to adhere to the very high standard to protect patient privacy for using their data. So there are safeguards around those, and we have always been trying to do our best to not put patient privacy at risk while we are reporting those findings, doing this research to understand how we can better serve our community to make sure the treatment works for everybody. I think it's really a mutual effort that needs from our researchers and also from our patient communities. And I think the patient advocacy that you have been doing has been also super important to link the two parties so we can do better work together.
Totally agree. Well, hello from the person from Botswana. How amazing is that? But yes, like it's hard to hear. It's hard to see, just the disparities and the stress and just how hard it is. So thank you for joining us here today. So we have a question about like prevention. Person's asking, like, only breastfeeding was mentioned. What about the rest after you've already been diagnosed with breast cancer? What are your studies showing?
Probably the strongest factor that can reduce risk of breast cancer and all cancers really is physical activity. And the research has kind of shown that it doesn't really matter how much. What really increases risk is sedentary behavior, just not doing anything, not moving. So, getting up, walking around. I have an exercise bike at home. I ride my bike. Any kind of movement is better than not. And this is again and again and again in every research study we see physical activity reduces risk of getting cancer. And then also it really increases survival. And I know if after people have been diagnosed with cancer and they're getting treated, probably the last thing they want to do is exercise. But a lot of studies have found that it helps. It helps get through therapy and through treatment, even, you know, gentle exercises, just movement.
Yeah, I like to call it exercise snacks, you know, like
Yeah,
try, because sometimes it can be a little overwhelming. Because I remember being post-treatment, like that first like 6 months to a year was very hard. So any sort of movement, like you said, they could be like little snacks
yeah.
to walk around. Well, you know, we're hitting time. This, a lot of us are speechless right now. So I think we have to like kind of just process what you presented. And I want to thank you so much for taking the time to tell us, you know, and help us better understand, and that we're being taken seriously, that our health, the Black community and breast cancer, that we're being taken seriously, and we have wonderful people like you making sure that the research is known and the research gets studied.
And Megan, Claire, I have to tell you, this has really become a national priority now at the level of the National Cancer Institute. I'm part of the Breast Cancer Research Foundation. Estee Lauder has pledged millions of dollars to try to get at understanding breast cancer in Black women and outcomes. So there's going to be a lot of attention on this.
Well, any last words before we officially wrap up here?
Well, thank you so much for inviting us, and we're working hard to try to help figure out this problem so it can be, you know, addressed.
Yeah, thank you very much for this opportunity.
Well, thank you. And everyone, don't worry. Once we have the recording ready, we will let you know. Anyone who registered, they will get a notice, and then we will also have this up on our website. And make sure to check out Share's website for upcoming educational programs, support groups, our podcast. And don't forget to follow us on social media as well. Please take a moment to fill out the survey at the end of this webinar. It'll pop up as soon as we close out. This survey is anonymous, and we do look at all of the feedback. That helps us with future programming. And again, Dr. Ambrosone and Dr. Yao, thank you so much for your time. And thank you everyone for coming.
Thank you, everybody.
Thank you.
Bye-bye.